All right, so hi everybody. Today I'll be presenting results from a prospective study to examine responsiveness of the cleft-Q scales following 3 cleft-related operations. So the target population of this project were individuals with orofacial clefts, including cleft lip, cleft palate, and cleft lip and palate, which are the most common craniofacial congenital anomalies. The incidence of orofacial clefts in Canada is approximately 400 to 500 infants born each year. The prevalence ranges from 11 to approximately 15 per 10,000 live births. On the left-hand side of the image that you can see here is Dr. Karen Wong, who's a plastic surgeon at SickKids, who spearheaded the development of the cleft-Q patient-reported outcome measure after a surgical mission where this image was taken. So patient-reported outcome measures are tools that are designed to collect patient-reported outcomes, and patient-reported outcomes are reports that come directly from the patient about how they function or feel in relation to a health condition and its therapy without interpretation by a physician or anybody else. So the cleft-Q was developed in 3 phases. Just briefly, in the first phase, a systematic review was conducted to determine what concepts have previously been measured in patients with a cleft lip and/or palate. Then in a qualitative study, in-depth interviews were held with 166 patients in high-income and lower-income middle countries. This led to generation of preliminary scales. Additionally, cognitive debriefing interviews and expert clinician input was used to refine these scales in an iterative process. And then in the second phase, these preliminary scales were administered to a large international group of patients with CLP in 12 countries. Over 30 medical sites participated. And this collected data was then analyzed using the modern psychometric method of rash measurement theory to shorten the preliminary scales. And then finally, in the third phase, further tests assessed the validity and responsiveness of the cleft-Q scales. And this presentation today reports results of the assessment of responsiveness of the final cleft-Q scales. So just briefly, in this table, you can see a list of psychometric properties that have and or will be examined for cleft-Q. So content validity was examined in the first phase, structural and construct validity, as well as internal consistency were examined in the second phase. And in the third phase, cross-sectional construct validity, which was reported in a different publication, and internal responsiveness, which is reported today, were examined. And then future studies will aim to examine the rest of the psychometric properties. So responsiveness is an ability of an instrument to detect change in scores over time. And internal responsiveness is a subcategory, and it refers to the ability of an instrument to detect statistically significant and clinically important change over time. And minimally important difference is the smallest difference in scores in the outcome of interest that patients or proxies perceive as an important deterioration or improvement. And so the aim of this publication was twofold: to examine internal responsiveness of the cleft-Q scales, that is, whether change in scores before and after surgery were statistically significant and clinically important, and also to estimate minimally important difference of the cleft-Q scales, which are the smallest change in scores that patients perceive to be important. And so how did we do this? So the third phase study was conducted in 3 countries: Canada, United States, and America. United States and England. And we collaborated with 6 different centers, which you can see here. The research ethics approval was obtained at these sites in Canada and the United States, and from the National Health Services and hospital sites in the UK. So patients were eligible if they were ages 8 to 29 years at the preoperative assessment undergoing either rhinoplasty, orthognathic surgery, or cleft lip scar revision. Orthognathic surgery is jaw surgery that usually patients with a cleft lip and/or palate undergo. Each participant completed a core set of cleft-Q scales that included appearance scales such as face, nose, nostrils, and health-related quality of life scales such as psychological and social, before and 6 months after each cleft-related surgery. And then additional scales were administered, such as teeth, jaws, ellipse, and cleft lip scar to individuals undergoing the orthognathic or jaw surgery, as well as the cleft lip scar revision surgery. So recruitment methods varied at each site based on the preferences of that site and the logistics. Individuals who did not complete the postoperative assessment at the initial request were contacted up to 3 times by phone or email. And if no response was received after the 3rd contact, the non-respondent was considered lost to follow-up. So analysis. So the assumption of normality was examined through assessment of skewness and kurtosis and normality plots with significance tests. If the skewness and kurtosis values were below an absolute value of 2, the data were considered normally distributed. If normality assumption was not met, the non-parametric equivalent test was used for the analysis. So internal responsiveness was assessed using the distribution-based approach. So in this approach, rash transform scores were examined using the paired sample t-tests and calculating 2 effect size estimators, Cohen's d as well as the standardized response mean. Then the 2 internal responsiveness hypotheses were tested for each operation. So the first hypothesis was that the effect sizes on the appearance scales would be larger than on the health-related quality of life scales because the health-related quality of life construct is a more distant construct than appearance in the context of cleft-related surgery outcomes. And the second hypothesis was that the effect sizes on the appearance scales examining aspects of appearance most affected by surgery would be larger than on the appearance scales examining aspects of appearance less affected by surgery. And so what we mean by that is that, for example, for the rhinoplasty sample where individuals undergo a nose surgery, we would expect higher scores on the nose scale as opposed to the face scale, for example. And then we calculated minimally important differences. So calculation of minimally important differences was attempted using the distribution-based as well as the anchor-based approaches. So with the distribution-based approach, the scale scores pertaining to the half effect size as well as half standard deviation were calculated. And for the anchor-based approach, a single item global rating of change in construct being measured, such as, for example, appearance, was used, and the mean change in scores corresponding to a category a little better than before my operation was computed. So for sample size, just quickly, the aim was to recruit 50 participants per surgery, and we did not anticipate any limitations because SickKids alone performs a lot of these operations annually. Right, so our results. So a total of 93 participants were included in the phase 3 study. 23 of these participants actually did not complete the postoperative assessments. So these non-respondents to the postoperative assessments were similar to respondents in terms of mean age, type of operation, and gender, but were more likely to live in England rather than Canada or United States. The sample size by type of surgery were as follows. For rhinoplasty, we had 31 patients, orthognathic surgery 21, and cleft lip scar revision 18. The time between the pre and postoperative assessments ranged between 5 months for rhinoplasty to 7 months for cleft lip scar revision. So first, we examined whether change between the pre and postoperative scores was statistically significant. So for the rhinoplasty sample, a statistically significant change was observed for the face, nose, and nostril scales. For the orthognathic surgery sample, statistically significant change was seen for face, nose, teeth, jaws, and lips scales. And then for the cleft lip scar sample, statistically significant change was seen for the nose, lips, and cleft lip scar scales. And after looking at statistical significance between the pre and postoperative scores, we determined the effect sizes for each operation for each scales using 2 distribution-based methods, as a gold standard approach has not been determined. And then based on the attained effect sizes, we were able to determine whether our hypotheses met the whether our results met the predetermined internal responsiveness hypotheses. And so as you can see, all hypotheses except for one met the prediction. The last hypothesis was not met because according to the Cohen's d effect size estimates, the nose scale had the highest effect size, followed by the lips and cleft lip scar in the cleft lip scar revision sample. And so although this was not expected, this result was not entirely surprising, as the cleft lip scar revision surgery has previously demonstrated improvement in appearance of the nose and the nasolabial region. And further, the lip revision scars tend to be more visible and take longer to mature than the rhinoplasty scars, thus offering another explanation for the smaller improvement on the lips and cleft lip scar scales compared to the nose scale within the 6 months time frame. And additionally, the sample size was small for the cleft lip scar revision individuals. So this result may have been seen because of the smaller sample size. And then the two distribution-based approaches were attempted to calculate minimally important differences. So both methods were employed for comparison, and because a gold standard distribution-based approach has not been determined. So these were our results. And as the distribution-based approach solely relies on the statistical characteristics of the scale scores, it was important for us to also attempt the anchor-based approach to calculate minimally important differences. However, the anchor-based approach could not be performed as the distribution of responses to the category a little better than before the operation in anchor questions designed for each surgery sample was too small to move forward with the analysis. Nevertheless, future research will focus on employing the anchor-based approach to confirm the minimally important differences estimated using the distribution-based approach. We had several limitations to our study. So as mentioned, inability to meet the intended sample size of 50 participants per operation. And we intend to replicate the results in a larger sample moving forward. Also inability to perform the anchor-based analysis. And again, we intend to try the anchor-based analysis again in future research in a larger, more culturally diverse sample. Another limitation was the time between the pre and post-operative assessments, and it varied between sites, and that's something that we will closely have to monitor in studies moving forward. Also, any deviation in management of the orofacial cleft could have introduced additional variability to the post-operative scores, and that's something that's more challenging to monitor because surgeons sometimes will select a different technique to repair cleft lip and palate, and that's a little bit more challenging to monitor. However, protocols need to be put in place to make sure that there is very little heterogeneity. Also, inability to include school function, speech distress, and speech function scales, and further research will be done to test these scales as well. And so in conclusion, there is evidence to suggest that the cleft-Q scales are responsive to cleft-related surgical treatment. Minimally important differences were estimated. However, further analysis via the anchor-based approach, which is the more preferred approach, in a larger, more culturally diverse sample is warranted. Just wanted to thank all of our collaborators around the globe who have worked with us tirelessly to help us bring this project to closure. Thank you very much.